Hello.
Hello there.
Hi, my name is Sierra and I'm going to be your nurse today. I have a couple nurses that are going to be with me throughout the day. I have Sharonda and I have Rachel here, and then Bree will be in at some point throughout the day as well, okay? Alright. And what was your name?
My name's Connor. This is my wife, Megan.
Okay. Hi, guys. It's nice to meet you. So we're going to be taking care of you today. We're going to be going over your urinary complications, kind of figuring out what's going on there, running some tests, you know, things like that, so we can figure out what's going on, okay?
Okay.
First, can you go ahead and give me your name and date of birth?
Yes. Connor Wigginson, April 7th, 1960.
All right, perfect. So I have a few questions before we begin with everything, okay? What is your current urination pattern? Like, how often do you urinate, and like, what is the urgency like?
So I go to the bathroom about all the time, and it feels like every time I go, I can't get everything out.
Okay. And do you have issues with, like, during the night? Do you have to get up often during the night to pee, or?
Yeah, all the time, actually.
Okay, and what about the urine, though? Like, is there any, like, strange color to it at all? Do you notice any blood at all?
No, not that I've noticed.
Okay. All right, good. So we're going to go ahead and do an examination now. Have you recently used the restroom?
Yeah, I actually just did right before you guys came in.
Okay, perfect. So the healthcare provider is going to come in and do that, and we're going to step out, and we'll be back in just a little bit, okay?
Okay.
During this time, the healthcare provider will palpate the prostate, causing the patient to feel the urgency to urinate. The patient will bend over the examination table or assume a side-lying fetal position. The assessment will involve size and consistency of the prostate. The BPH will involve a uniform, elastic, non-tender enlargement. Massaging one of the prostates may be done to obtain a fluid sample to rule out prostasis, which is an inflammation of possible infection of the prostate.
All right, we're back.
Welcome back.
All right, Connor, the doctor wants us to do some lab work. Is that okay?
Yeah, that's fine. What are we going to do exactly?
So we'll be doing a urinalysis, a urine culture, a CBC, which is a complete blood count to check for urinary infection or blood in the urine. We'll be checking your BUN and creatinine to evaluate the functioning of your kidneys. We'll also be doing a PSA, which is a prostate-specific antigen test, and that's more like for a prostate cancer screening, sorry. During your prostate exam, if the doctor expressed any fluids, we will check that fluid for culture and sensitivity.
Okay, that works for me.
So what about any diagnostic tests? I know the doctor had mentioned something about possibly doing something called a transrectal ultrasound or something, and he said something about where they'd enter a transducer into the rectum and view the prostate and the surrounding structures, or like a cystoscopy to view the interior of his bladder, or the bladder neck and the urethra, and a bladder ultrasound for right after he voids to see if there was like any residual urine.
Yes, we will conduct those tests once the doctor is ready for him.
Okay, so according to the doctor, he's diagnosed you with benign prostatic hyperplasia.
Okay, can you tell me what that is exactly?
Of course. So benign prostatic hyperplasia is a disease also known as BPH. It is when there's an abnormal overgrowth of cells and tissue in the prostate. This creates inflammation, and the prostate gland swells up, extending up and inward toward the bladder. Due to the enlargement of the prostate, urinary flow is affected, causing issues such as urinary retention, urinary leaking, or incontinence.
All right, I just thought I was peeing my pants just because I was getting older.
Well, now I know why I've been doing your laundry so much more.
That could be due to the retention of urine. He is having what is called overflow urinary incontinence. This is when the urine is leaking and squeezing around the enlarged prostate, creating dribbling. Sometimes we can even see urinary tract infections and bladder stones form due to the retention and the stasis.
So can it get any worse than it is right now?
Yes, it could. Sometimes we can see the prostate get so large that you're unable to avoid at all. If this happens, then you need to seek care immediately. There have been also times that we have seen chronic urinary retention where urine gets so backed up that there's a gradual abdominal distension of the ureters and enlargement of the kidneys if BPH is not treated.
Well, it's a good thing we brought him to the hospital in time. So what could have caused this to happen to him?
Yeah, I would like to know too, because the doctor told me what was wrong. I looked it up and I found out that it's more common for males, but the problem is not exactly clear what it is. The relationship to aging is the only known factor I also saw that black men younger than 65 needed treatment earlier than white men, and lower urinary tract symptoms are much more common in black men than in white men. Coffee and caffeine intake have also been associated with increase in risk for progression of existing BPH2. Genetic susceptibility, family history of cancer, and obesity and metabolic syndrome are also risk factors.
You are very correct. About 40 to 50% of men between the ages of 51 and 60 years old experience some varying from mild to severe. Just like the symptoms that you mentioned, men may experience difficulty in starting and continuing urination, reduced force and size of the urinary system, sensation of incomplete bladder emptying, straining to begin urinating, and post-void dribbling or leaking.
So will I be able to get better from this, or will I always have this issue?
So the prognosis for people with BPH is very good. There isn't a cure for BPH. However, treatments can help with your symptoms. Mild symptoms may not require treatment. There's also medications that can be used, surgery, and minimally invasive treatments that can treat more severe cases.
So first off, we would try treating it with some simple lifestyle changes such as your diet. You should avoid liquids before bed or going out a few hours in advance. Caffeine and alcohol may increase your need to urinate. You should have a low-fat diet and include vegetables and citrus fruits. You also need to be physically active and maintain a healthy weight. When it comes to medications, we can use one medication or multiple combinations together. There are alpha-1 adrenergic antagonists, which act to relax smooth muscle in the bladder neck, and 5-alpha reductase inhibitors, which act to reduce prostate size. These are usually used together because they work better in combination. 2 commonly prescribed drug regimens include finasteride and doxazocin, and dutasteride and tamsulosin. Sometimes other drugs may be used for managing urinary symptoms like nocturia, including low-dose desmopressin, which is a synthetic antidiuretic analog, which will make you hold on to fluid.
Okay, so what about like surgery? Because I know the doctor said that's a possibility as well.
Yeah, if the doctor decides to do surgery, then there are 3 options. There's a transurethral resection of the prostate, which is where a resectoscope is inserted into the urethra, which is used to remove the excess tissue, which makes it easier to eliminate urine. And the average stay in the hospital is about 1 to 2 days after that. There's also a transurethral incision of the prostate, which is when the bladder neck and prostate are cut, which relaxes the opening of the bladder, making it easier for the urine to flow. This is usually used on men with smaller prostates. There's also a simple prostatectomy, which is an incision into the abdomen or done laparoscopically to remove the inner portion of the prostate gland, which leaves the outer segment intact. There are risks with all of these surgeries, and some of them include a UTI, frequent urination, blood in urine, incontinence, blood clots, and erectile dysfunction.
Okay, thank you very much.
All of that doesn't sound too bad. So how do you care for him while he's here in the hospital?
So while your husband's here at the hospital, we're going to provide the best care we possibly can for him. That's our first priority. And then while he's also here, we're going to start him on some medication to treat his benign prostate hyperplasia and his urinary retention. We will also monitor his input and output to make sure he is drinking and eating correctly and enough, as well as make sure he's going to the bathroom and urinating. That way it shows us if he's still retaining his urine or not. If he does end up retaining the fluid, we might have to do a bladder scan just to see how much fluid he truly is holding in his bladder. And if the bladder scan if the urine in his bladder is more than 400 milliliters, then we'll have to do an in and out cath. This sounds a little scary, but this is just to help his bladder not hold as much fluid, as well as it's trying to train the bladder to release the urine itself. And then as the nursing students with the nurse, we have also discovered that his nursing diagnosis is urinary retention related to obstruction in the bladder, neck, or urethra, as evidenced by the dysuria and nocturia.
All right, cool. I appreciate all that information you guys have given me. You guys were awesome.
It's no problem at all. Do you guys have any other questions for us?
No, I think you guys covered everything that I have, so appreciate it.
Thank you.
Thank you.